الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله. نحمد الله على هذا الاجتماع المبارك. It's a pleasure really for Saudi Society of Blood Disorder to have this webinar as part of the SSBD Hematology webinar series, which has been started almost a year ago. And our tonight session, it will be about hemophilia musculoskeletal management, complication, and probably Dr. Hazzah is remember over years, we are dreaming to have teams of musculoskeletal and hemophilia to manage those patients. And successfully now we have more than one team in Saudi Arabia, and quite proud of the King Faisal Specialist Hospital Riyadh team, Dr. Hazzah Al-Zahrani, Dr. Sam Al-Ramih, and Mr. Ahmed Mahrous, whom really we are proud of you in Saudi Arabia to treat those patients. For our attendees, you are always welcome. And I would like to attract your attention to the discussion where please keep Q&A for question and questioning to the speaker, and keep the chat for the chat. So I'll not look into the chat for questioning, but I'll look into the Q&A for the question. So please save the Q&A for questions. Again, I would like to attract your attention that this is a webinar from this SSBD. There is no CME hours for this webinar. There will be a certificate. And because of the high number of the attendees coming to this webinar, and already we have reached the maximum before we start. So all those people whom they would like to follow, they can follow us on the YouTube and Twitter, and so there is other time to follow us, to follow these lectures. Today's Dr. Hazzah is going to talk about the musculoskeletal complication in hemophilia as an overview. Dr. Hussam Al-Ramih is going to talk about when it is time for surgery in hemophilia, and Dr. Ahmed Mahrous, he will talk about physiotherapy role in hemophilia. And I'm going to start with Dr. Hazzah Al-Zahrani. Dr. Hazzah Al-Zahrani, he is consultant adult hematology at King Faisal Specialist Hospital Riyadh, and he is one of the pioneers in the field of hemophilia, not only in Saudi Arabia, but worldwide. Hazzah has a lot of publication in the field of hemophilia, and I consider Hazzah as the dynamo of hemophilia in Saudi Arabia, and he is the starter of hemophilia service in Saudi Arabia. Without further ado, Hazzah, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ahmed, for the very nice introduction. It's a great pleasure and honor to be with the colleagues to discuss the issue of management of musculoskeletal complications of hemophilia. And without any delay, we'll just move to the topic. This is the building of our King Abdullah Cancer and Hematology and Liver Transplant Department in the hospital here, 21 floor building. So the objectives of my talks are to give an overview on musculoskeletal complications of hemophilia, to understand evolution and consequences of hemophilic synovitis and arthritis, and give a brief superficial overview on the management of hemophilic complications and synovitis, and share with you very superficially on the experience of radioactive synovectomy here at King Faisal Hospital. As you all know, hemophilia is a congenital bleeding disorder manifesting mainly with musculoskeletal bleeding symptoms. Commonest is being hemarthrosis, seen in 70 to 80% of patients with severe and moderate hemophilia. Then muscle and soft tissue bleed are seen around 10 to 20% of cases, and other major bleeds are seen in around 5 to 10% of cases. Luckily, the life-threatening bleeds are seen as, sciatic bleeding is seen on only less than 5% of patients. The most common site of bleeding, as we said, is the joint and muscles, and these are the joints that are most commonly affected: the knees, followed by elbows, ankles, shoulders, wrists, hips, and then other joints. And depending on the severity of the disease, bleeding episodes may be frequent and may happen even without any apparent cause. And in children with severe hemophilia, the first bleeding manifestation typically manifests and starts when the child starts to crawl and walk. And in patients who develop hemophilic arthropathy, if this or hemophilic or hemarthrosis, if inadequately treated, the bleeding keeps repeating itself in the joint, there will be progressive deterioration of the joint and muscles, and severe loss of function due to loss of motion. Muscles will become atrophic because of disuse and pain that happens and evolves in these muscles. Patients develop pain and joint deformity and end up with contractures, and this can be as early as seen as early as in the first or second decade of life. So arthropathy develops if inadequately treated, but in the second decade of life, where hemarthrosis develops, and this also may be associated with persistent chronic synovitis, which by itself can lead to recurrent hemarthrosis because of the hypertrophied, friable, and fragile synovium. This leads to irreversible damage and advanced cartilage loss and progressive arthritis. And the final outcome will be progressive joint deterioration, loss of motion caused by the physical damage of the joint and the extremely painful joint, progressive fibrosis of the synovium and the capsule surrounding the joint leads to joint swelling. And with time, with fibrosis, joint swelling subsides and joint becomes ankylosed. And as time goes by, with the fibrosed and fixed joint, the pain may diminish or disappear. And this will ultimately lead to incapacitation and disability, flexion contractures, and significant loss of functions. Diagnosis can be made clinically or with imaging studies like ultrasound and MRI, which may show soft tissue swelling, osteochondral changes, cartilage narrowing, bone erosion, subchondral cysts, collapse of the articular surface, angular deformities, and fibrosis and bony ankylosis. Pathophysiologically, when the blood is within the joint space, macrophages start to digest this blood, and the red cells in the synovium, in the fluid, will start to irritate and trigger the synovium to release some inflammatory markers like interleukin 1B and tumor necrosis factors, and the release of matrix metalloproteases dissolve the surrounding cartilage. The destroyed red cells within the joint leads to release of iron and hydrogen peroxide, which release some free radicals that cause the chondrocyte apoptosis and the progressive destruction of the cartilage. So at the level of the synovium, there is inflammation, hyperplasia, angiogenesis, and hyperfibrinolysis. The cartilage gets progressively deteriorated and the chondrocytes are apoptosed, and the bones becomes osteoporotic with cyst formation and osteophyte formation. Some proliferative markers like MDM, murine double mutant to oncogen, and c-Myc are overexpressed, and that was shown in animal studies, showing the very hyperproliferative status of the synovium that leads to progressive destruction of the surrounding tissue. The goals of treating patients with hemophilic arthropathy is to improve the joint function, relieve the pain, and assist the patient to continue and to resume normal activities of their daily living. That options of therapies will depend on the stage of the condition and the symptoms of the patient and the patient's lifestyle and functional abilities and the available resources. One of the major goals is to relieve the pain. I commonly use the COX-2 inhibitors Mobic 7.5 to 15 milligram, depending on the patient's weight, acetaminophen, and opioids. Physiotherapy will be discussed by Ahmed. And then if patient was not on prophylaxis and start to develop target joint by meaning that if the patient develops two major joint bleed within the same joint in 6 months, then a patient should be commenced on prophylaxis, which can be continued for several months and then reassessed if the patient can tolerate without it. Otherwise, he can remain on the prophylaxis. Other measures that will possibly be discussed by Ahmed, and then adaptation to environment like home and school and work by helping patients to participate in the community and employment and facilitation of activities of daily living. Dr. Rumayh will discuss the surgical interventions, but for surgical interventions, there have to be adequate resources, including sufficient factor concentrate and adequate factor monitoring to make sure that the treatment during the surgical intervention is safely performed. And of course, the detection of inhibitors and other supportive services that Ahmed may mention, including rehabilitation post-operatively. This is one of our patients who developed a progressive joint damage in the left hip. You see there is almost no space left between the head of the femur and the socket of the hip joint. And ultimately, Dr. Imran did a total hip replacement. He had a remarkable improvement in his day-to-day activities after the joint replacement. This was done, by the way, under the coverage of factor 7 and imosuzumab. This is another patient. Actually, this is the same patient who developed severe arthropathy of the knees and had surgery, total knee replacement because of this progressive severe arthropathy, where you see here there's almost no joint space with no cartilage in the left knee. The same thing also in the right knee. Another patient with severe arthropathy and subchondral cysts. Another site of bleeding is the muscle bleed. This results typically from a sudden stretch or injury. And it's very important to identify and properly manage patients with muscle bleed early to avoid permanent contracture and deep bleeds and pseudotumor development. Bleeding in the deep flexor muscle group of the limbs is also a special area where immediate management to prevent permanent damage and loss of function is very important. These include bleeding into iliopsoas muscle and superficial and deep posterior compartment of the lower leg and flexure group of the forearm to prevent contractures and nerve damage like femoral nerve damage and also Volkmann contracture in the hands. Typically, muscle bleed will present with swelling, pain, and functional impairment, and patient will keep their limb in their comfortable position, and they develop tension and tenderness upon palpation. Ultrasound can be done to confirm this, but history and examination is enough to diagnose these cases, and treatment with hemostatic agents immediately before performing investigations is very important, especially in areas where the bleeding may be associated with neurovascular compromise. Another major musculoskeletal complication of hemophilia is pseudotumor development, where inadequately treated soft tissue bleeds, typically muscles in the long bones or the pelvis, leads to progressive bleeding within that muscle, and new vascularization, where the patient will develop bleeding again in the same hematoma. This can lead to a life-threatening condition and can reach an enormous size with pressure to the adjacent neurovascular structures and can lead to pathological fractures. Typically, easy to diagnose by seeing a localized mass that is not responding to factor replacement therapy and with progressive compressive symptoms. Diagnosed easily by radiological examination, including CT or MRI. And the management depends on the site and size and rate of growth and the effect of that and the adjacent structures, but always starting with the factor replacement therapy for several weeks. And if the MRI shows a reduction in the size, then continuing on factor replacement and possible consideration of surgery when this tumor size has shrunk becomes easier than doing surgery with a larger size tumor. Aspiration with the fibrin glue injection can also be considered. Surgical treatment is the ultimate therapeutic intervention that is used in most of the pseudotumor patients. Ablation and arterial embolization have been tried. I have tried it in one patient. Radiation therapy, we tried it in one patient. And as we said, surgical excision, and unfortunately, some patients may end up with amputation. This is one of our patients who developed a huge pseudotumor in the psoas muscle. You see this mass in the pelvis measuring 14 centimeters in size, and you see it here on MRI with around 30 centimeters size. You see the kidney here is compressed with dilated pelvic calyceal system. And he also had massive right leg swelling and neurovascular compromise because of this mass. This patient was treated surgically with a prolonged complication and ultimately commenced on emicizumab with a very significant improvement in his overall condition and quality of life. Joint bleeds leads to, as we said, early synovitis, then chronic synovitis, then degenerative joint disease, and ultimately joint immobility and incapacitation. This is a vicious circle where hemoarthrosis causes more synovitis, synovitis causes more hemoarthrosis, and that ultimately ends with the joint damage with secondary soft tissue contractures and muscle atrophies and angular deformities. This cycle can be broken by prophylaxis and other interventions that we'll discuss here. And the aim of treating synovitis is to deactivate the synovium as soon as possible and try to preserve the joint function. And this can be done by prophylactic factor replacement therapy, which can be short-term or long-term. I think most of the patients, when they end up with the synovitis, they would require a very long-term prophylactic therapy. And this, of course, would require intensive physiotherapy. Prophylactic therapy can be, if the patient was on prophylaxis and developed arthropathy, then you may have to intensify the target trough level to reach higher than what we commonly use of 1% to maybe 5% or whatever level that will maintain the patient bleed-free. Synovectomy should be considered if synovitis persists with frequent and recurrent bleeding and not controlled by other means like regular prophylaxis. There are several options of synovitis. One will be chemical synovitis. The second is radioisotope synovarthrosis. And the third is surgical synovectomy. The chemical synovarthrosis is done by intraarticular injection of antibiotics like rifampin or oxytetracycline. This is a painful procedure and requires weekly administration and frequent factor injections, in contrast to radioactive synovectomy, which is done using a pure beta emitter like yttrium. This is a highly effective measure and have few side effects and can be done in the outpatient setting. Usually we give a single dose of clotting factor replacement therapy just before the procedure. And we involve colleagues from orthotics and physiotherapy to do intense rehabilitation after the procedure. The isotopes that are used are either rhenium and yttrium. In Kingdom of Saudi Arabia, we have only used yttrium-90. And this is because of the fact that it has a short half-life. These two drugs, the two radioactive materials, have short half-life and have a short diameter of tissue penetration of around 1 to 5 millimeters. So that limits the potential toxicity to surrounding tissues. We mentioned the synovectomy being a vicious circle, and the fact that there are encouraging results of the radioactive synovectomy to be adopted. This is one of our patients where we had 4 millicurie radioactive yttrium injected into the left shoulder, and he had significant clinical improvement after the synovectomy. We typically discuss the option and physically evaluate the patient in details. If they still have some range of motion and synovial hypertrophy clinically, we refer them for the synovectomy by ordering and collaborating with radiology, Dr. Shalan, and fluoroscopy colleagues, and with physiotherapy and orthotics. And this involves very intense arrangement and orchestration by our colleague nurses who are very much involved in this. Mahmoud Abu Riyash had a major role in arranging all of these. We get we order the yttrium, we prescribe the factor replacement, and prepare the pain medication, get the consent, we do baseline MRI, do blood tests to make sure that the patient has no inhibitor, and check the factor level. And we order the radiological tests. Patients are referred to orthotics to have splint to be applied directly after intra-articular injection to the affected joint. They also are referred to physiotherapy to do whatever measures to relieve the pain and strengthen the muscles, improve the joint range of motion. They also are booked for MRI in 6 months after the procedure. And we try to patch the intervention where we book 3 patients at one time to avoid wasting of the radioactive synovectomy, the material, because very expensive, and make sure that the patients adhere to their appointment, because if they get delayed, the radioactive material decays and we lose its efficacy. So we did a patient-reported outcome assessment by assessing the pain and range of motion. We have done 47 patients, and you see here that the patients reported with regards to the frequency of bleeding, almost all of them has reduction in the joint bleeds, except the 4 patients you see here, where they had no change in their frequency of joint bleeds. So 10% had no change, 40% had more than 60% improvement in the range of and the frequency of bleeds. Also, the pain score, according to the patients, have improved, but 10% did not. 19% has a reduction to 0. 42% had a reduction to from 8 to 10 to 4, and 23% had a reduction to a score of 2. With regards to range of motion, most of the patients also reported a significant improvement in the range of motion, reaching around almost 80%, like what is published in with other centers. The joint size to most of the patients was thought to be improved, and in around 3/4 of the patients. So synovitis and hemophilic arthropathy, if untreated, may lead to permanent disabilities. Prophylactic therapy prevents disabling hemophilia complications. Radioactive synovectomy using yttrium is an effective measure in treating hemophilic synovitis. And this involves extensive pre, intra, and post-procedure arrangement and planning and coordination with involved services to obtain successful results. Pain score and range of motion and frequency of bleeding was reported by our patients to be significantly reduced after the treatment with radioactive yttrium. Thank you very much for your attention.
Thank you, Dr. Hazza, for this really interesting presentation. I have a request that in 1 or 2 minutes, can you tell us what is hemophilia?
Thank you. I'm sorry, I think we have more than 3,000 attendees.
Exactly. That is why I'm asking this question, just to know what is hemophilia.
I was thinking that I'm presenting only to physicians and to, internists, but hemophilia is a congenital bleeding disorder caused by deficiency of factor 8 or factor 9, which are the important factors for clotting factors to prevent bleeding when it happens. And this disease has variable severity, and it usually affects males more than females because it's transmitted to the X chromosome from the mothers who are carriers of the disease. The disease is classified into mild, moderate, and severe depending on the residual factor 8 or 9 level. Normal people have a factor 8 of around, or 9 of around 50 to 100. And patients with severe disease have less than 1% factor 8 or 9. Patients with moderate disease have a level of around more than 1 to 5%. And patients with a level of around above 5% have a mild disease, and they typically would not bleed spontaneously. Patients with mild or moderate disease may bleed spontaneously or with trauma. I think that's a brief overview of this disease.
Thank you, Dr. Hazza. I have a question from Irwina Celan. How long can you live with hemophilia? I think she's talking about the lifespan.
You know, nowadays with the availability of the clotting factors, patients with hemophilia lead almost normal life if they are appropriately treated. Untreated patients, unfortunately, they die in the second or third decade because of serious bleeding complications. So nowadays, we are talking about complications of hemophilia like in the elderly, like atherosclerotic disease and other, vasculopathies, and how to manage these, because these patients live beyond the age of 60 or 70. So with adequate factor replacement, patients with hemophilia have a normal lifespan. And they actually have, some of them, compete in, athletic sports and other activities, and they are, competing with healthy people. And I think there are champions, hemophiliacs, who have won international, sports activities more than against normal healthy people.
In pediatric, it is more clear that people they are using the prophylaxis, but still in adult, people keep asking about the prophylaxis, how useful it is. The old question whether the prophylaxis can lead to inhibitors, and then it is difficult to treat inhibitors. So how about prophylaxis in adult hemophiliacs?
We use prophylaxis as dictated by the clinical phenotype of the patient. So if the patient has frequent bleeding symptoms, have arthropathy, or have a lifestyle where they require higher level of factor replacement, we use prophylaxis, and we have a very low threshold to adopt prophylaxis in these patients.
Okay. What can cause contraction in hemophilia patient? Something we don't see nowadays, but we had seen it before.
The progressive recurrent joint bleeds that are suboptimally or treated or are untreated. This is the main cause of contraction, basically inadequate treatment.
Here is a question from Shihab. Is there any new protocol for hemophilia patient before taking them to operation? I think he means pre-op preparation.
Yeah, I think the WFH has released the guidelines last year about the management of hemophilia, and they put guidelines on the dosing of factors before surgeries, depending on the severity, mild or moderate or surgery, or major surgery. So for major surgery, we typically target a factor 8 or 9 level of 100%, at least in the first 1 or 2 days. And then on day 3 to 5, we give around, we target around 80%. And as we go beyond 3 to 5 days, we reduce the target to lower levels unless the patient has any bleeding symptoms. So basically, it's a dynamic decision depending on the patient, because patients can have other bleeding, causes of bleeding, surgical causes, or any other reason. So in general, if you have no adequate resources, if you don't have enough support to monitor the factor, and you have no enough clotting factor concentrate, I think doing surgery is unsafe, and these patients should be managed in centers where all the supportive services needed are available.
This is a question from Muhammad. Is there rule for stem cell transplantation
in hemophilia? There's no rule. Yes. To my understanding, there may be some studies using gene therapy somehow modified and I have come across some of these, but these are far away from being considered. The gene therapy in hemophilia is much simpler than what is used in an adeno-associated virus that has or an lentivirus that has the genetic material of the factor 8 or 9 is injected intravenously, and it incorporates in the liver and start producing so stem cell therapy has no role. If we are asking about the regular stem cell transplant, it has no role in treating these patients.
A question from Aya: does all newborn are checked for hemophilia?
No, this is not part of the neonatal screening because it's very rare. But patients with family history and those hemophilia carriers, mothers who are carriers, they have to be screened and have to be very vigilantly looked, and followed up by hematologists and neonatologists at that time. But it's not part of the routine neonatal screening tests.
At what age hemophiliacs they present?
Depending on the severity, I have a patient who presented at the age of 70 because he has mild hemophilia, or 60 actually, sorry, after an aortic aneurysm surgery. But patients with severe disease, they present when they start crawling. So children, when they start walking, so before 2 years, they may manifest with difficulty in walking and hesitation and limping, or swelling in the joints.
Last question from my side about the musculoskeletal joint issues. Do you believe that we need to check on the joint, like some sort of screening every year, for example, particularly in adults, or to do MRI or ultrasound or something as such, before they present with severe joint problems?
Thank you. I think this is a very valid question. And even in those who are on prophylactic regimen and when they have no clinical symptoms of bleeding, if you do some imaging studies, you may discover subclinical joint bleeds. Well, indicating, and even those who are on prophylaxis, that some of these patients who are on prophylaxis may have, to be treated with a higher trough level than what we normally use of 1%. Thank you.
Thank you, Dr. Hazza. It's my pleasure to introduce Dr. Hussam Al-Rimih. Dr. Hussam Al-Rimih is consultant orthopedic surgeon at King Faisal Specialist Hospital. Dr. Hussam has graduated from British Columbia Canada, and he has a fellowship from there on lower limb reconstruction surgery. He's program director residency at King Faisal Specialist Hospital. Myself and the other hemophilia interested group in Saudi Arabia, we are quite happy to have Dr. Hussam in the group of hemophilia in Saudi Arabia. And Dr. Hussam will talk from the surgeon's overview. Dr. Hussam, the floor is yours.
Okay, thank you so much, Dr. Ahmed, for this great introduction. And thanks for having me. I'm really a pleasure to be part of this event tonight. I hope you can all see my screen.
Yes, it is. We can.
Okay, great. Excellent. Okay, so first of all, thanks for the invitation. I mean, I'm really privileged. I'm privileged to be with you guys. And to be honest, I'm really happy to know that there's a society. I mean, having hemophilia society in the kingdom is something that we desperately need. And as the first way to treat such kind of pathology here. And that multidisciplinary approach is something that I really honor and love here. Okay, so first of all, this is another picture from the same building that Dr. Hazzah showed, but I'm showing it at night and maybe from a better angle maybe. So our clinic, combined hemophilia clinic that's run by Hazzah, it's in the 8th floor in this building. And it happens once a month where we all gather together and see patients together. And I have no relevant disclosures in relation to this talk. And I'm invited here to talk about hemophilia, and please mind some of the, let's say, the level of science here, given the broad spectrum of audience. I've been told that it's mainly physicians and allied health medicals, so covering the whole spectrum sometimes is extremely difficult. But why are we seeing lots of musculoskeletal involvements here? And why have orthopedicians gotten involved in the late years? It's simply because hematologists have been doing a good job in the last years. Before, we don't used to see them. They usually die early, and they don't live long enough to have these musculoskeletal manifestations. And I remember we had a surgeon in Canada who used to tell us that it's a single gene disease, and it used to be treated by circumcision in the Middle East. So patients get circumcised and they bleed to death, and you don't see them later on. But now with advanced therapies and let's say the good level of healthcare that we have in the kingdom here, we're starting to see them age, as Dr. Hazzah mentioned, and we're starting to see the manifestations. So as patients grow older and older, they bleed into their joint, they're active, and we see most of these manifestations. And this is an example of an X-ray that Hazzah, I think, showed, Dr. Hazzah showed something similar to it, which is end-stage arthritis or arthropathy in a knee. Okay, so, and we've been talking about this just off the air, the number of people on prophylaxis. So in the recent years, we've seen a tremendous increase in the use of prophylaxis. Thus, we have seen people who live longer, who have much lesser deformities, and sometimes milder symptoms. And each time you prevent a bleed, you save a piece of chondrocyte. So with every bleed, you destroy a joint, and every time you save them that bleed, you're gonna prolong the life of the cartilage. And as Dr. Hazzah mentioned in his talk, commonly affects the knees, elbows, and ankles, and that accounts for about 80% of all the joints affected. And in this talk specifically, I'm going to focus on knees because more than half of them are in knees. And some may ask, why is it knee, elbows, and ankles? Because these are the joints that have the synovium. So you do have some synovium in the hip, you do have some synovium in the fingers, and you do have some synovium in the shoulders, but it's nothing compared to the large synovium you have in the knee or the ankle or the elbow. So the bigger the synovium, the more prone is it for bleeding, the more destruction happens. And this is an example. And believe it or not, it could be so ugly. So just show the arrow here. So it could be something like this here, and the X-ray there on the far left, where it shows that elbow that's completely destructed, both in the AP and lateral, or an ankle that is severely arthritic, or a major swelling on the bottom right there that is severely arthritic, if I had to show you the X-ray. Okay, So, and some may ask me, what do you base the judgment of surgery on? Okay, so if a patient comes to you with end-stage arthritis, do you base it on X-ray or the amount of destruction or in the patient's symptoms? Patient's symptoms is something relative or more, I would say, subjective that we tend nowadays in medicine to shy away from and try to base our surgical decisions on, let's say, better objective methods. So recently, orthopedic surgeons in general and medical physicians in specific started to implement something like functional outcomes, just like Dr. has illustrated in his talk. And what I do, I administer something like this to them. It's a functional outcome score specific to the knee. We translated it and validated it in Arabic, and it gives you a score from 0 to 100. So, and evidence has shown if you have scored below 70%, your quality of life and the function of the knee or that joint has been severely affected, and that surgery will help you. Why do we bring this up? Because we know for a fact that 20% of our patients who have a total knee replacement are unhappy with their total knees. And I'm sure that every one of us has a relative who underwent a total knee and is not happy. And we call them in the orthopedics the unhappy 20%. Why does that happen? We're still not sure yet. It's under investigation, but we think it's because rushing into surgery when the patient did not need it. So that's why we're moving to a more objective way of advising for surgery. So if a patient comes in the clinic or seen in the combined hemophilia clinic with arthritis, I give him this. He fills it up, I score him, and based on that, I make my recommendation. So surgical treatment in terms of total knees. That's the topic here that we're going to talk about. It's been described, let's say, a long time ago, but it came to light in the late 2000s with the advancements of hemophilic treatment. And I would say that it was relatively good compared to the normal individuals. So these are 3 articles. And you see the last one down here that shows about 94% survival in 20 years. Though I would dig deep in that patient cohort, you never know. There was no stratification whether they were severe, moderate, or mild, but that's close to the survivorship that we have in normal knees. So that paper specifically started encouraging orthopedic surgeons to pursue doing total knee replacements. In the past, there was a taboo. Nobody would touch a hemophilia patient. In fact, a patient with inhibitors was an absolute contraindication, and it was every surgeon's nightmare who wanted to bother and do a hemophilia patient while you can do a straightforward knee arthritis. Okay, so thanks to Dr. Hazat, when I first came back, he formed this integrated practice unit. We don't have all the members, but I would say we have the hematologist, we have the surgeon, we have the physiotherapist, and we have the nurse. We're still missing a lot, but this is what I would say an ideal setting, what would be an ideal team to look after hemophilias in a center. I would encourage every hospital in Saudi, or not every, big hospitals at least, to establish these units if they want to tackle this problem. It's never a one-man job. It has to be through an integrated team headed by the hematologist. Our friends in anesthesia have their algorithms and preoperative treatment. So they do their planning also before surgery, and they do their preoperative assessment, their intraoperative, and their postoperative assessment. One very important point to bring here is the mood of anesthesia that I'm going to talk to in a while. So for these specific patients, there's no regional, spinal, or epidural injections. You may end up with a bleed in the cord that have devastating or permanent nerve damage. And I remember Dr. Hazat mentioning to us that you may lose an airway. You may lose an airway because of a traumatic intubation if you don't administer the factor first. So who is offered surgery? Let's reinforce that the surgery is only to improve the quality of life. It's not a life-saving surgery. So if the patient's quality of life is not affected, why offer it? If he's happy with his quality of life, don't offer it to him. Okay, let's remember it's not a life-saving surgery. I discuss the risks and benefits with the patient. Remember, it's the patient's knee. It's not your knee. Okay, so it's his knee. And as we say, nothing about him without him. That's the patient. And patients usually tell you when they're ready. You may see a patient who has a very bad look in X-ray and who scores very poorly on our outcome questionnaire, and simply says, "I don't think I'm there yet," and he elects to wait, which is perfectly fine. They will tell you when they're ready. Other thing is to pre-plan it. Let's say we have a patient who came to the clinic and we decided to do surgery on him, and we gave him all the risks and benefits, and Dr. Hazza and his team arranged the factor and did their blood work and everything. And now it's in the surgeon's hand. To take the stress off the surgeon, I move part of the operation from the surgery itself and do it on my desk. How do I do that? I pre-plan it in my office. Instead of stressing during a surgery, we see a marker here. We do an X-ray that has a marker. So we have exact, accurate measurements, and we start templating it. And we start playing with these components. So I walk in the surgery knowing exactly what kind of size am I going to put, how am I going to supposed to cut the knee, and how am I going to supposed to place the component, and what's the alignment of it in the knee. If you think about it, that's about 30% of the surgery done at your desk, not in a stressful OR environment. And of course, blood work inhibitors and levels, inhibitor and factor levels are done before. Most of them have infections, so we standardize those. I mean, standardly we do in hepatitis and HIV screening because a lot of them carry bugs. Though we take universal precautions for all of them. Okay. The day of surgery. So you choose your anesthetist. You don't go with an anesthetist that you never met. You choose your anesthetist. You know that he's a competent one. He's comfortable dealing with hemophilia patients. He's comfortable to deal with patients who could suddenly be hemodynamically unstable because there's lots of stress on them too. The moment the patient is in the room, I call Dr. Hazza and I make sure that he's around because that's such big relief. And the last thing a surgeon wants is being alone in the OR with a bleeding patient, even though he's not in the room, but knowing that he's in the hospital and he has your back kind of gives that sense of relief to the surgeon in the OR. The first drug that we always give to the patient in the operating room is the factor. Nothing else goes before the factor. You put an IV line and you administer the factor. You don't intubate first. You may lose the airway, as I said, with a traumatic intubation, and then the patient collapses or dies on the table. All cases go for general anesthesia. No one goes for regional anesthesia. So, and that sometimes puts some pain control issues after surgery, but they have to live with that. Okay, what makes a hemophilia knee different to the surgeon? So first of all, the mean age of patients who have hemarthropathy is about 27. And that's a very young age. A young age population that has huge demands, active, they want to go back in sports, they want to run, they want to live their life. It's not the typical 60-year-old who wants to go to the mosque and come back. So you have a patient who has high demands from his knee. So that's the first difficulty. Difficulty number two is an abnormal deformity. So if we see here, there's what we call wide notch, okay? There's a squaring of the condyles, okay, both in extension and flexion. And there's generalized osteopenia that's affecting the tibia and the femur. And associated many times with flexion contractures, reaching as bad as 30, 40, 50 degrees, and sometimes varus and valgus deformities, which makes it even more challenging. So all these require us to use specific implants and requires lots of time to expose it and requires special cuts and good preoperative planning. So a typical hemophilia knee would take from you easily 2 to 3 hours, while a regular knee would last an hour and a half. Okay. Add to that, patients have muscular atrophy, they have axial deformities, and this ends up with what we call prosthetic instability. So we end up putting a massive implant here. You see this implant here that has stems going up and down, simply because you cannot stabilize the joint because his muscles are weak, the deformities were huge, and he had to straighten the knee. So these are the challenges that the surgeons have during surgery. And if you notice, these are not easy issues to deal with. And that's what makes lots of surgeons shy away from them. It's not only the bleeding that makes them freak out. Sometimes it's the deformity in itself. And during the surgery, the surgeon has to be swift without cutting corners. There's no cutting corners when doing total knee replacement. You have to do it once because there's no coming back here. We don't want a revision. We want it to last for life. So it's one surgery that you're going to do for a 30-year-old patient. You don't want to see him again as long as he lives. Careful hemostasis is key. I start very carefully, controlling the smallest bleeders as you go, conducting a complete synovectomy, moving all the synovium, and don't cut tissue that you don't need to cut. During the closure, make sure you leave no dead space, no drains. If you put a drain, it's gonna bleed. And surgeons get surprised. Well, the drain is full. Yes, it's full because it's doing its job. It's supposed to be full, and because you put it there. The third thing, which I always emphasize on the fellows and the residents, you deflate the tourniquet and watch for bleeders. Control them. Do your best. The best chance of controlling your bleeders is the time of surgery before you close. And I check again and again and again. I like to see a nice dry dressing afterwards. I don't want to see a soaked wound. Okay. And literature has shown, as well as the data that Dr. Hazza presented, there's a humongous improvement in functional outcome scores, including general quality of life outcome scores, like the short form 12. And we noticed that in our small cohort of patients too, that we haven't published about that. We're hoping that we could do something soon in the future, but we noticed that too. And we know that this group of patients have already disabling quality of life because of these diseases. So if you have a low score, there's room for benefit. If you have a high score already, which is the regular population, you may not benefit that much. But there is room for benefit in hemophilia. I encourage surgeons not to be shy from them and tackle it in the good way. But as I was told before I returned back to King Faisal, that if you don't have a dedicated hematologist with you on board, just don't start it. And these are the small series that we reported in literature. Literature is pretty shy on the number of series or number of studies published in joint replacements in hemophilia. And you can see here that most of them are 20 small numbers, 23, 19, 51 is the largest, and with variable reports. So, but basically, they all reported good subjective, some objective outcomes there. So it's an encouraging, it's a very rewarding surgery if it's done correctly and done in the proper manner. And as I said, this would never happen if we did not have a dedicated hematologist, nor would we ever try to pursue this without them. Because when we say bleeding happens and you can't control this, surgeons can't do anything. It all goes down to the hematologists, and we all start looking at them. And it's one of the most stressful circumstances that you could ever be in, seeing a bleeding patient in OR and you stand there hopeless. Thank you so much, Dr. Ahmed and Dr. Hazza and the team for having me, and open for questions. Thanks a lot.
Thank you, Dr. Hussam, for the very, very nice overview about the musculoskeletal surgery. And as a physician, I hate to see surgery. I hate to see blood. Actually, I get scary. Anyway, but we need to do something as such. A question to you from myself, actually. When we have a patient with hemophilia, let us say that with a knee joint issue, and of course we need to do scoring for that patient. Do we jump immediately to the knee replacement, or we start medical therapy, atrium synovectomy, or we depend on the score, how bad the score is, and we jump to the surgery?
Yeah, that's an excellent question, Dr. Ahmed. So basically, it goes with an algorithm. the way I look at them, is he a patient who has arthropathy or not? So if it's pain alone with no arthropathy, I start thinking about other methods like synovectomies, like scopes, or like even draining the hemarthrosis. But if he's a patient who already has arthritic changes, what you're doing here, you're delaying the problem. That's when I go with the sport. So the simple question is, does he have arthritic changes on X-ray, not on MRI? MRI always shows arthritic changes. If somebody MRIs my knee right now, it's going to show arthritic changes. I go with the X-ray. If he has arthritic changes on X-ray, I go with the score. Before that, if it's only pain, I go with Iturum, as Dr. Hazza mentioned, or sometimes arthroscopic synovectomies.
Thank you, Hussam. Many they are asking about the COVID-19 vaccine for the hemophilia. Actually, we recommend all of them, they take the vaccine and they do not need to have factor before the vaccine, only a compression after the vaccine. And you need to tell them that you are a hemophilia patient from this point of view, and maybe you ask your physician if there is any other precaution or contraindication in particular. But generally speaking, hemophilia, they can take the vaccine even without factor. A question from Dr. Tawfiq. Is an orthosurgeon. Do you use regular knee prosthetic or long stem?
Okay, so that's a more technical question. So this depends. I mean, thanks, Dr. for the question, first of all. So that depends on the stability, first of all. So I usually go with what we call the minimum constraint. And mind this, Dr. Ahmed, so if people don't understand what I'm saying here, the minimum constraint, we mean by that a knee that has minimal components. And I test it as I go. If I see that the knee is not stable with the small non-stemmed knees, okay, I go with a stemmed knee and I put stems. The target of the surgery is to send a patient to the recovery room with a stable, full range knee, whether he does it with stems or not. But you use the less invasive, less constrained prosthesis as possible.
Thank you. A question from no name. Total knee replacement patient with hemophilia. How early he may start standing or walking after surgery?
Yeah, that's another common question. The answer is immediately. So they usually walk day one. If you do it early in the morning, you can make them walk from day one. There's no problem here. The limiting factor in walking is the pain. If their pain is controlled, they can walk. The knee is stable from the moment it's put in. So there's no restriction on activity, motion, or weight bearing here.
Thank you, Dr. Hussam. It was very, very interesting talk, and I'm quite happy to listen to the surgeon and watching what they are doing. Thank you, Hussam.
You're welcome.
Last not least, Dr. Ahmed Mahrous. Dr. Ahmed Mahrous, he is a senior physiotherapist from King Faisal Specialist Hospital. He has graduated from King Saudi University. He has a lot of education and certificate, a lot of awards, and he did work in a lot of hospitals in Saudi Arabia and outside. Dr. Ahmed, he is going to talk to us about the role of physiotherapy in hemophilia, which I believe myself, it is one of the major rules that need to be done for every patient with hemophilia. Dr. Ahmed, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Hopefully that the screen is showing. I don't know. Assalamu alaikum.
I can't see your screen. If this is your screen.
Yeah, perfect. So, yeah.
But I can't see whether this
Assalamu
is
alaikum wa rahmatullahi wa barakatuh. I would like at first. Yeah, it's showing right now?
Yes, yes, sir.
Yes, yes.
Yeah.
Go ahead.
Yeah, perfect. Yeah, perfectly. So I would like at first to thank Saudi Society of Blood Disorder for their invitation, and thanks to my colleagues for excellent presentation. I think they made my job easier to focus on the role of physiotherapy in hemophilia. I would like to explore more about this role, which is يعني a part of a multidisciplinary team that has a very extensive role in treatment of treatment plans of hemophilic patients. So my presentation will be focusing on the role within role of physical therapy within the multidisciplinary team, and then we'll shift into musculoskeletal and physical therapy intervention. Then what we should do an annual assessment for hemophilic patients, and ending up with the education and health promotion aspect towards hemophilia patients. So as a role of physical therapy that's involved in the care of hemophilic patients, they have a basic role from starting from the time of diagnosis of the patients, and should be participating in the musculoskeletal assessment, treatment, and even education throughout the person's lifespan. So mainly joints to be affected and muscles to be affected by hemophilia are commonly, it's been explored by Dr. Hussam that the ankle, knee, and elbows are the commonly affected, which has a large synovium membrane. So beside the having a synovium, that it's as an articulation, it's an hinged joint structure. So it has a 1 degree of freedom of movement, which is flexion and extension. However, ball and socket joints, such as hips and shoulder, have multiple degrees of freedom of motion, which is move around without even strain. And plus, the second reason that hinge joints are not covered by protective muscles, as hinge and whereas ball and socket joints are covered by many protective strong muscles. So that might limit the forces that going through that particular joints. As we've mentioned, that elbows, knees, and ankle most commonly bleeding joints. And it might alter the biomechanics and even the muscle accessibility and strength throughout the hemophilic patient's lifespan. So through assessment, assessment should includes baseline. Assessment should include baseline and longitudinal assessment throughout the lifespan. So we need to start the assessment since patients got diagnosis, for the sake of maintaining their condition of a healthy condition of joints and preventing further complication that might happen to their muscles and musculoskeletal system. Also, we need to determine through assessment the sites of acute bleed, assisting with differential diagnosis, either it was a joint muscular bleed or fibrosis. Superficial joint, superficial soft tissue versus muscle. So we need to differentiate between each affected structures. Also, we have like an important role in pre-operative and post-operative. So based on ongoing or criteria of surgical intervention has to be assessed by physical therapy preoperatively, optimize their joints function, the surgery to ease off their role as operative and to provide the proper instructions to the patients, either pre or post-operative. Treatment, usually we intervene with acute bleeds to the skeletal system, either muscular or joints, acute and chronic synovitis, chronic arthropathy, dealing with the pain, with different levels. Also, we deal with limitation of function and participation. So we need to provide an instructive, constructive treatment plan to optimize and increase the level of independency and improve their hemophilia patients' functional level. Also, post-operative rehabilitation program should be done also as a role of physical therapists to reach the goals of surgical intervention that done on a certain joint. In terms of education, education plays a big role in terms of education should be applied to different aspects or on the key players that working with hemophilic patients. So at first, patients and families should be educated regarding prevention and how to implement an exercise-based program into their lifestyle, and it has to be gradually fitting their available functional level, available strength and joint condition. So it has to be tailored according to their functional and musculoskeletal condition. So identification and management of bleeds and musculoskeletal complication of bleed disorder. So we need to educate the patient families how to control the acute bleeds and how to do during the acute bleeds, and even later on how to prevent bleed from recurrency with help of other disciplines. Patients and family regarding also has to be educated regarding the healthy active lifestyle throughout their lifespan. So as I've been mentioned before, so promoting a healthy active lifestyle is an essential role for the primary team of hemophilia patients. School personnel, with respect to their appropriate activities for a person with bleeding disorder, has to be educated as well. And activity modification should be introduced that will allow necessarily safe participation. So we can tailor or modified activity for the hemophilia patients to fit their physical and functional condition. All people who are responsible for patient safety, such as babysitter, teachers, coaches, etc., on appropriate immediate treatment of a suspect bleed. So education, how to properly treat an acute bleeds also should, instruction has to be given to people who take care of such patients. Other core members regarding identification and management of musculoskeletal complication of bleeding disorders. So also physical therapist has to gain special, skill how to deal with such patients. So in terms of level of exercise intensity, exercise prescription, even in terms of range of motion exercises and prescribing proper exercise for such patients. It's not an easy job to be applied, because applying an aggressive exercises might increase patients' bleed and might cause harm for patients' condition and joints. So having a special training on dealing with such patients, hemophilia patients, would add a benefit to those patients, and would construct a proper programs, rehabilitation programs that fit those patients. So I would like to talk about the assessment of acute. As you know, the musculoskeletal bleeding is a key characteristic of any bleeding disorder and results in permanent damage to the joint and muscle. Accurate diagnosis is a key of ensuring correct treatment. So early intervention and early diagnosis would lead to an excellent outcomes and better, let's say, outcomes of joints condition and muscle condition as well. The earliest symptoms of musculoskeletal bleed is pain. However, not all pain is due to bleeding. So pain is a very crucial and important factor for dealing with hemophilia patients. So it's a factor that we need to respect when we prescribe an exercises, when we progress within the exercises, and even when we want to increase either the range of motion or strengthening training for such patients. Symptoms of some musculoskeletal bleeds can mimic other conditions such as psoas bleed, presenting like appendicitis. So the criteria of assessment, we need to sit with the patient. We need to know his history of present condition. We need to know the details of his bleeds when it happens, and what if he on certain prophylaxis or not. And if he's what management he's done, did he took this factor? Is he on a regular prophylaxis or not? All of those history we need to have before we intervene with a patient. We need to know his past medical history, the frequency of bleeds, and we need to know, look into his also X-rays, and we need to know his joints condition. We need to know his severity of if he has a joint of hemarthrosis or any genetic changes happening to his affected parts. All of those stuff may have a very crucial and important role in the future outcome of these joints, and even when we design and rehab program for this condition. Also, we need to look into specific objective criteria, such as palpating the joints, looking into the joint lines, such as looking into the end feel, the joint feel, the crepitation, all of those objective criteria, measuring the range of motion as well, looking into his muscle power, testing his muscle power also. Lots of objective criteria applied within the assessment. So this is a table that differentiates between the joint bleeds and muscle bleeds, how to detect which of which. So joint bleed pain often preceded by tingling and sensation or aura. So a patient could tell before the bleed has happened that he's expecting a bleed or a certain a certain bleed on a certain joint. However, if in the muscle bleed pain, if muscle contracts or stretches, so once you stretch the muscle, patient will feel pain, or even when contract his muscle, he will feel pain. So pain will be present on all muscle function, either it was lengthened or contracted. Usually with joint bleed, joint on palpation is warm. However, patient might have rapid joint swelling as well. Joint held in a position of comfort, so open back position. So patient you might have a level of comfort range of motion. However, end range usually, or a certain range, patient might feel pain. So also you might feel tenderness when touch or move the joint itself. Also, patient will be significantly reduced range of motion due to the swelling, present swelling. Also, altered gait or inability to weight bear on a certain limb due to presence of pain, swelling, and even the ongoing bleeding. However, in muscle bleed, patients might feel muscle tightness, limited range of motion due to the bleed on a certain muscle. Also, superficial muscle warmth, hematoma will be presented, swelling as well on the soft tissue. Deep muscle with potential for compartment syndrome, paresthesia, distal pallor, or pulselessness, example for arm, calf, or iliopsoas. Iliopsoas bleed, it's quite critical, as Dr. Hazza mentioned. It has a differential diagnosis as well, and we how to go deep into the characteristic of the our patient presentation. Usually, patients might feel pain in groin, thigh, hip, or even in lower back. Usually, he will be on a certain structure such as hip flexion and sometimes extend rotated, just to go into the least, let's say, or comfortable joint position. Patients might feel like abdominal tenderness, tingling or numbness in distribution of femoral nerve, weakness of quadriceps and or decreased patellar reflex, unable to stand straight like a lordosis due to the contraction of that particular muscle. Knee might be flexed, and patient will be unable to place flat foot on the floor, so he might be walking in tiptoeing gait. Also, the patient will be unable to lie flat, so patient will be tending to lie on his sides with flexed hip. So development of abnormal postures after bleeds, that's our role, to do an biomechanical assessment with patients with present joint or let's say muscle bleed, or have an history of joints or muscle bleeds. So usually patients tend to go for an adaptive posture, that adaptive postures due to their degenerative changes on their joints or muscle condition. So those are the common adaptive postures to be present within different joint bleeds or muscle bleeds. For example, for the knee, patients with knee joint bleeds might be expected on their position of comfort might be flexion. So patients will be in pain when you force their end range of extension. So usually they might be walking on flexed knee with hip in a flexion position and ankle on their walking on the forefoot. So might be presented with plantar flexion to compensate the presence of pain. So potential problem, patients might develop stress on the ankle and overuse hamstring and weak quadriceps. So that's why early detection of such postures might lead to an early correction of those postures, and might lead to improve the outcomes of the joints and muscles condition. But it lead to contractures and huge degenerative changes on certain joints. For muscle bleed, for example, hamstring muscle bleed might lead to patient might be presented with knee flexion and hip extension as a position of comfort. Also, they will be as a structural habitual posture in knee flexion position. So the potential problem, patient might have an altered gait with knee flexion and walking on their toes, which is quite similar to the knee joint bleed. So that's an example of adaptive behaviors after the joints or muscle bleeds, and how we can biomechanically assess those adaptive behaviors, and how we can, an early intervention to those patients might lead to a better outcomes in terms of joints and muscle conditions and health. Treatment of acute musculoskeletal bleeds. So our primary goals as a physical therapist in a treatment following musculoskeletal bleeds is to regain pre-bleed status as soon as possible while preventing new injuries or re-bleeding again. So detecting an early intervention of physical therapy might lead to regain their pre-condition, functional condition, joints or muscle condition, pre-bleeding, and might prevent also future bleed by introducing a well-structured and tailored exercise program with the help of the different disciplinary team. Goal of PT is reduce pain, reduce swelling, restore joint range of motion, restore muscle length, also restore muscle strength, return to regular activity, including sport, if they have a habitual sport activity that they are enrolled on. Plus, for patients, or let's say hemophilia patients that enrolled in sport activity, we need to explain to them on the level of safety of different sport activities. So not all sport activity might fit different hemophilia patients. So we need to tailor, or let's say choose the least or let's say the more safe sport activity, and fit their condition and level of bleeding condition as well. Acute management also, we need to look into the factor replacement as prescribed by the hematologist. So factor or let's say dosage adjustment, and make sure that they're ongoing their factor before our intervention. Protection of the injury with the splint and or slings, especially in acute condition or acute level. So we need to minimize the loading on the certain joints to allow better healing of certain joints. Also, complete rest of injured area, including no weight bearing or non-weight bearing for joint or muscle bleed, and no ambulation for psoas bleed. So we need to allow a full recovery for certain bleed before we start to do gradual weight bearing or loading activities. Ice for pain relief and to control bleed, compression and elevation has to be introduced from day one of their bleeds. Exercise progression, we need to introduce exercise as long as the swelling started to subside. We need to start loading, and exercise has to be within pain limits and tolerance. So we need to respect pain level. We shouldn't push the pain against, or let's say across his pain tolerance. So we need to go with the patient's pain tolerance. We need to take an attention to a sign or symptoms that would indicate a new bleeding. So patients, we need to communicate with the patient frequently and to make sure that exercise fits his condition, acute condition. After bleeding has stopped, exercise has to be introduced, and it has to be gradually in terms of intensity. We need to go with the low intensity exercises, then we progress according to their condition. Also, aids that might enhance mobility, such as crutches, cane, walker, whatever, that might improve or that might help patients to start to get them as early as possible to mobilize as early as possible. Exercise program has to be done to maintain or regain range of motion, strength, flexibility. Also, that should include balance and increase his muscle endurance and energy. The use of splint, low load, prolonged passive stretching techniques might be a useful approach to regain patients' range of motion and flexibility after, let's say, a long period of bleeding. Aquatic exercises is an excellent and safest, let's say, exercise to start with. And even long-term exercises, it could be introduced as a lifetime exercises, as it's safer for the joints, as it's decreased the load when under the water. So underwater exercises might be beneficial for patients with changes or patients with hemoarthrosis condition. Functional training, including regain normal gait and enhance ADLs, activity of daily livings, and engagement in sport activities according to their ability. Other treatment methods might be introduced as well. Joint protection techniques such as proper body mechanics, ergonomics, adaptation, orthotics, or bracing. As mentioned earlier, that doing like a biomechanical assessment, alignment assessment would have a better quality of general function, such as gait and function, such as squatting and daily activity of daily function. Manual techniques might have good outcomes in terms of pain, such as very gentle muscle work, such as trigger point therapy and mobilization after full subside of patients' joint bleed or muscle bleed, to control their pain and deconditioning of their muscles and joints. Electrophysical modalities might have a benefit to their pain. It might be used as a pain control after recovery of their bleeds. Acupuncture might have a role also on pain control as well. So, not to be considered that we can use treatment can be used with caution. One thing has stopped, and according to the usual clinical indication and contraindication. Musculoskeletal surgical intervention. So, as Dr. Hussam and Dr. Azza mentioned, that surgical intervention is a very important role to optimize patients' musculoskeletal function and to have them mobilized and independent as much as possible. So it's a team decision, and each of part of the team has a role on the patients. And physical therapy has an important role on optimizing patients' function pre-operative and post-operative. So we have a range of options of intervention, such as simple ones, such as intra-articular injections, or such as steroids injections, or even complex decisions, depending on the complexity of the joints condition, such as arthroplasty. Pre-operative, we need to meet patients goals and expectations. So there has to be a goal for our intervention. And the goal, we should agree on a goal that we need to optimize patients' function and independence. Prehabilitation program has to be introduced to optimize the joints condition. So we can educate the patient for certain and simple exercises to optimize their joints function before going to the surgery. We need to discuss with the patient the post-operative plan, such as outpatient care, post-surgery care, inpatient post-surgery care as well, such as location, frequency, and duration. We need to respect patients' timing and dedication during post-operatively in particular. As in any surgical intervention, patients there's a possibility of complications, so such as pain. The patients may not be able to distinguish between the post-operative pain from pain due to new bleeding. So this has to be also introduced to the patient. Patient has to know the every single details about what he expect during after the surgery, especially after the surgery, the expected pain after the surgery, and we need to look into let's say, watch out his possibility of bleed during and after the surgery. So the risk of bleed may be mobilization and predispose to ankylosis. So the risk is there, but having the all part of the team in would minimize that risk in particular. Delayed wound healing and infections might also happen. Difficulty regarding pre-operative range. Okay, so few slides to be done. We have the annual assessment. Patients has to be assessed annually to minimize to look into his bleed history, impairment. So we need to use certain scores such as health joints hemophilia scores to look into his joints conditions such as range of motion, repetition, strength, and so on. We need to look into his pain and if he developed a new disabilities or new conditions or other bleeds in different joints. Also, we need to assess his level of function and participation through functional independent hemophilia score. So the guide of exercise prescription, if the patient is not taking factors, there's no harm. We have like a different level of intensity. Patients might go through, start with low level of intensity, then he might progress according to his tolerance and condition. Exercise has to be slow and steady. We need to reinforce the patient to do a proper quality during the exercises. We shouldn't underestimate isometric exercises, as isometric exercise is the safest to start with. So no gain with pain. We need to respect patient's pain. We shouldn't push patients against his pain. Patients has to have individualized program. We shouldn't have like a recipe that should be distributed to all patients. We need to respect each unique condition of each patient. We usually start with ability and body weight as a resistant training. We need to remember his functional requirement and his limitation, acknowledge it, to work on improve it. We shouldn't forget proprioceptive exercises and balance exercises. We need to achieve a normal range of motion, or at least to optimize his range of motion to functional joints and functional ADLs is very important. We need to implement a program that fits his daily activity requirements and tailor it according to his needs. So thank you from my side.
Time over.
Your son. Yes, I'm done.
Thank you, Doctor. I have a couple of questions for you here from the audience. Maria, she is asking, does the physiotherapy for the patient with hemophilia causing bruises or blood clots? Dr. Mahrous, can you hear me? Hello? You can hear me? Well, I don't know if I lost Dr. Mahrous, but let me answer this question. Actually, usually it is very well planned type of physiotherapy, and in many cases that we consider factor for those patients. So it is planned process. I'm not sure if Dr. Ahmed is still with me. Dr. Ahmed, can you hear me, Dr. Ahmed? Okay, Dr. Ahmed is connecting.
Sorry, yeah.
Yeah, okay.
Yeah, sorry, I think I'm having an issue with the internet.
It's okay. Maliha asking when to use weight bearing.
As I mentioned, regarding the weight bearing, we need to start to use weight bearing as the swelling and the joint bleeds are started to subside. So we can start to do weight bearing. We can use an assistive aids such as crutches, crutching and walker as a beginning to minimize, to promotes patients' mobilization and functionality. But we need to start weight bearing as long as the joint as the bleeding of the joint start to subside.
question from no name. Which physical agent and modalities allowed for those patients without causing harm?
TENS would be recommended to control pain.
And the last question, what appropriate specific exercise program you will recommend to improve the mobility and function for hemophilia patient? And I add to that, do you recommend hemophilia patient to go for fitness type of exercise? Do you need to take some precautions?
That's an excellent question, and actually that's let's say a very important point to be introduced to the hemophilia patients. Actually, we need to promote this point and importance of this point. Patients has to go to fitness programs, but with the supervision of their physical therapist. They need to have also supervision of physical therapist and even the hematologist. They need to have a regular prophylaxis, and also we need to assess their readiness of starting to do fitness programs. So we need to assess their joints and everything before they start to do such training. But in general, yes, they need to go for strengthening program for if they don't have, but we need to teach them how to go gradually from light level to moderate level. Also, we need to emphasize that they shouldn't go for high intensity training as long as they have like a certain or permanent joints dysfunctions, or let's say joints degenerative changes, just to to get like to work with precaution. This is a very important point. Otherwise, exercises to start with, usually we start with the light kind of exercises that depends on body weights, and such as active range of motion exercises with less loading at start, until their muscles become more activated and the range of motion become more flexible, so we can progress in terms of exercise intensity. So usually we start with isometric kind of training, static contractions. We also implement active range of motion with no weights. Then once we assess their muscle condition and range of motion, we might apply some stretches exercises that less harm and less pain. They need to feel the stretch itself, not the pain itself, and we progress according to their improvement in terms of strength and flexibility.
Thank you, Dr. Ahmed Mahrous. Thank you, Dr. Hussam Al-Remeh. Thank you, Dr. Al-Zahrani. Thank you for SSBD. Thank you for the attendees. I want to attract your attention that this session is recorded, and you can see it later on at the YouTube channel of the SSBD. It was really very prestigious session. I have enjoyed all the 3 talks so much. Thank you. جعله الله في ميزان حسناتكم. نلقاكم قريبا إن شاء الله. السلام عليكم.
وعليكم السلام ورحمة الله. Thank you.
عليكم السلام
ورحمة الله وبركاته. Thank you very much.